Hello, my name is Genevieve Frazier with Rogers Behavioral Health. Thank you so much for joining us today. Joining me is Dr. Sarah Lee and Dr. Peggy Scallon to discuss the assessment and treatment of borderline personality disorder in adolescents. Before we get started, I'd like to give our participants a quick overview of our format today. We will have a 90-minute presentation, and to receive the CE credits, you must be logged in for the entirety of the program. Your attendance is tracked via Zoom login and logout records. A PDF of the PowerPoint, as well as a full list of references, will be available to you on your personal dashboard at ce-go.com. An email with the link to your personal dashboard will be sent out shortly after the broadcast ends. In addition, a recording of this webinar will be available within the next day or two on Rogers' YouTube channel for you to rewatch. Our speakers will give a 70 to 75-minute presentation today. And following the presentation, I will facilitate a question and answer session. If you would like to ask our speakers a question today, please utilize the Q&A button on your Zoom taskbar to submit your question. I will review all of the questions submitted, and we will address them in the Q&A portion of the webinar. Finally, we have enabled closed captioning for this program today. Now I'll turn it over to our presenters.
Genevieve, good morning. I'm Dr. Lee, and along with Dr. Scallon, we want to declare that we don't have anything to disclose. These are our learning objectives for this morning. And this is a snapshot of what we'll cover in today's webinar. To introduce ourselves a little bit, I'm a clinical supervisor here at Rogers, and I supervise one of our adolescent residential programs and our child residential program. I'm a licensed clinical psychologist, researcher, and mentor. I'm a white cisgender young adult woman whose pronouns are she, her, and hers. And I'll let Dr. Scallon introduce herself as well.
Hello, hi, I'm Peggy Scallon. I'm a child and adolescent psychiatrist, and I am the medical director of the Oconomowoc campus and also the Focused Depression Recovery Adolescent Residential Care Unit here at Rogers in Oconomowoc, pronouns she, her. Thank you.
The first topic that we'll go over today is how to assess for borderline personality disorder in adolescence. We'll go into measures that can be selected, how to have confidence in your diagnosis, and how to tell this condition apart from others that are commonly misdiagnosed in adolescence. To start, I want to give a brief review of some of the topics we covered in our 2022 webinar on this topic, specifically the myths about BPD in adolescence. The first and probably the most pervasive myth is that you can't diagnose someone with BPD before the age of 18. The truth is that the DSM-5 and the ICD-11 allow for diagnosis of personality disorders before the age of 18. And as Swales goes on to say, early intervention may be especially important as behaviors are less entrenched the younger the person. The second myth is that borderline features are actually normative in adolescence, so we can't diagnose it as a disorder. When people say this, they usually mean symptoms like moodiness, impulsivity, and interpersonal sensitivity. The truth is that we do have to take adolescents in their cultural context, but adolescents who meet criteria for BPD will be more extreme on these traits as compared to their peers who don't. Adolescents who meet criteria for BPD do exist. In the general population of adolescents, about 6% display borderline features, and about 3% meet criteria for a full diagnosis. In more acute settings, this number increases all the way up to around 75% of adolescents who present to ERs for suicidality. The third myth is that the symptoms can be better explained by another psychological diagnosis. The truth, as we'll discuss, is that it is really important to do careful differential diagnosis to tell BPD apart from other conditions. And our focus today will be bipolar disorder and PTSD. The fourth myth is that because adolescent personalities are still developing, personality disorder diagnoses would be inappropriate. The truth is that there is some stability in these traits, even in adolescents. In their study of adolescents presenting to the ER for suicidality, Greenfield and colleagues found that 76% of adolescents who met criteria for BPD at the baseline continued to meet criteria 4 years later. Furthermore, the American Psychological Association finds that personality disorder symptoms in adolescents are moderate to strong, which is similar to what we see in adults. The final myth is that BPD is long-lasting and treatment-resistant, and therefore too stigmatizing to diagnose. To the first point, treatments do exist for BPD, and we'll discuss some of these later in our presentation. To the second point, I'm not going to pretend that there isn't stigma surrounding this diagnosis, but withholding a diagnosis presents its own ethical issues. To quote Hannan and colleagues, quote, "Non-diagnosis of BPD is discriminatory because it denies individuals the opportunity to make informed and evidence-based decisions," end quote. Swale says, because there are treatments that are effective, withholding this diagnosis is unethical, whether that diagnosis is stigmatizing or not. So if you've made it this far, then you agree that there is compelling evidence for the existence of BPD in adolescents and compelling reasons to give that diagnosis where appropriate. The rest of this section will go over some ways to do that with confidence. First, I want us all to keep in mind that the assessment of personality is always challenging because the pathology will influence how the person responds to you. And people often aren't aware of their personalities. It's just the way that they see the world. So it's difficult to ask questions about personality features directly. Instead, it's really helpful to look for patterns in the way that your adolescent client describes themselves, their relationships to other people, and their functioning. Behavioral observations are always an important part of diagnostic assessment, and this is even more true with personality assessment. So pay attention to the ways that your client interacts with you. Do you see some of the patterns in the symptom criteria? It's also very important to get collateral information from people close to the client. For adolescents, the natural choice is going to be their caregivers. And the benefit of working with adolescents is caregivers are often more accessible during treatment than they would be for adults. Finally, Bozatello and colleagues recommend a combination of self-report questionnaires and the use of semi-structured or structured interviews to build confidence in your diagnosis. When choosing a self-report questionnaire, it's important to look for questionnaires that are specific to the symptoms or diagnosis of BPD. These are some of what we'll review next. Scallon and colleagues recommend that clinicians should screen for BPD for any adolescents who present with suicidal behavior or non-suicidal self-injury. And we believe that screening is a helpful way to begin the assessment process for clients you believe may need more intensive evaluation. It saves time and it prevents you from needing to use more intensive diagnostic methods with a large portion of your clients. It's very important to remember, however, that screening is not sufficient to give a diagnosis. Screening should be followed by a combination of chart review or taking a history, use of those behavioral observations of the way your client interacts with you, gathering collateral information from those close to the adolescent, and interviewing the adolescent themselves before arriving at a diagnosis. The next several slides will discuss some screening measures that are validated for use in teenagers. One of these is the Abbreviated Diagnostic Interview for Borderlines, or ABDIB. The ABDIB is derived from an older revised diagnostic interview for borderlines, which we'll describe later. Despite its name, the ABDIB is a self-report measure that takes about 10 minutes to administer. It demonstrates good sensitivity and specificity in adolescent populations. Now, for those who aren't familiar, sensitivity and specificity are two things that I'll go back to describe these measures, and a good screening measure should have a balance of both. Sensitivity is our chance of correctly identifying a true positive, That is, identifying BPD where it exists. And specificity is our chance of correctly identifying a true negative. That is, not identifying BPD where it does not exist. Another screening measure that can be used is the BPFSC-11, which is derived from the older BPFSC. Both of these in turn come from an assessment inventory that can be used for adults. The BPFSC-11 is briefer than the ABDIB, but also demonstrates somewhat lower sensitivity and specificity. As a further trade-off, these numbers come from an inpatient sample. I couldn't find record of how this measure performs in an outpatient sample in North America. The BPFSC can be accessed for free with scoring by reaching out to its first author. The McLean screening instrument for borderline personality disorder was developed from the DSM-4 criteria for BPD. It asks about each criterion in a yes/no format, with the final criterion about paranoia and dissociation being split into 2 questions. It takes less than 10 minutes to administer. The MSI-BPD had very good sensitivity and specificity on the initial sample of adult patients it was developed for, but in an outpatient sample of adolescents, shown here, performed a little less strongly. The next screening measure, the Borderline Personality Questionnaire, or BPQ, is a little longer than the others and gives a little more clinical information. It comprises 9 subscales that map onto the 9 criteria for a DSM-4 diagnosis of BPD. Despite its length, it takes a short time to administer and score because it has a yes/no format. Hanan and colleagues actually go on to recommend it as the screening measure of choice for BPD in a youth population, even above some of the others that I've already reviewed. This is because of its combination of sensitivity and specificity with high test-retest reliability and high diagnostic accuracy. The main drawback of this BPQ is its length, which may not be appropriate if you have other conditions of interest to screen for and don't want to overwhelm your adolescent client with a long packet. Another drawback is I could not find evidence of its use in individuals under 15 years old, and its creator did remind me it's primarily for adults. The BPQ can be accessed for free and with scoring by reaching out to its first author. On this slide, we cover some of the measures that we use here at Rogers to aid with our screening and also to track treatment progress for adolescents with BPD or borderline features. The first of these is the Difficulties in Emotion Regulation Scale, or DERS. Instead of measuring borderline symptoms per se, it measures emotion regulation more broadly, which is thought to be the core of many borderline personality disorder symptoms. The DERS comprises 6 subscales that include non-acceptance of emotional responses, difficulties engaging in goal-directed behavior, impulse control difficulties, lack of emotional awareness, limited access to emotion regulation strategies, and lack of emotional clarity. Higher scores indicate more emotion dysregulation. And at Rogers, we pay particular attention to the strategies subscale, where elevated scores indicate a risk of behavioral dysregulation. This subscale is the one that's also been found to be most predictive of non-suicidal self-injury in inpatient adolescents. The Borderline Symptom List 23 is meant to optimize the older Borderline Symptom List, which was 95 items long. We find this a useful measure, not just for screening, but for following the progress of borderline symptoms, although it usually takes a little longer than the DERS to show improvement. This has been a popular measure for efficacy studies of DBT for adolescents because it has moderate sensitivity to change. Despite the fact that it's been used in many studies, a lot of those don't report sensitivity and specificity. What's reported here is from an outpatient sample in China, where the sensitivity and specificity of the measure was good. The BSL-23 and the DERS can be accessed for free by reaching out to their first authors. In addition to a screening measure, because that will get us started but not give us a full picture, it can be helpful to use a diagnostic measure to increase your confidence. One of these that's validated for use in adolescence is the childhood interview for DSM-4 borderline personality disorder. This is a semi-structured interview with 9 criteria that map onto the criteria from the DSM-4. The clinician rates these criteria as being 0 for absent, 1 for probably present, or 2 for definitely present. To meet criteria for a diagnosis of BPD, the client must score a 2 on 5 or more of these symptom criteria. Pros of this measure are that it's not overly lengthy, and in Sharp and colleagues' study, it was easy for even non-clinicians to learn and adhere to. In fact, anyone who's done a symptom measure before, this will probably be very familiar in format. Cons are, like any semi-structured interview, it requires training to become proficient in this one. Another option for an interview measure is the revised diagnostic interview for borderlines. This measure includes 22 statements pertaining to symptoms of BPD. The statements can be grouped into 4 sections: affect, cognition, impulsiveness, and interpersonal relationships. It demonstrates good sensitivity and specificity and good inter-rater reliability. So when conducting an assessment for borderline personality disorder, it is important to choose measures that you can have a lot of confidence in. It's equally important to take a careful history so that you can rule other conditions in or out. We're going to go into detail about 2 conditions that are frequently confused for BPD, especially in an adolescent population. The first is bipolar disorder. A lot of these recommendations come from 2 psychiatrists, Kernberg and Yeomans, who work in a personality disorder care clinic. They say that the most important thing when making an assessment of BPD versus bipolar disorder is to make an accurate assessment of the presence or absence of a manic or hypomanic episode, and to determine whether that manic or hypomanic episode was significantly different to your client's usual personality. Something that's really important to think about here is whether the duration criterion was met. Were these symptoms consistently shown for at least 3 to 4 days? It's also helpful to consider the general nature of your client's relationships with others. Plenty of people experience relationship disruption during a manic or hypomanic episode, but if there's chronic instability in your patient's relationships, that's more of a sign of BPD. Keep in mind, it is possible to meet criteria for both of these conditions, but for that to be true, there still has to be a demonstrated manic or hypomanic episode. Now, just using personality measures, we can usually tell BPD and bipolar disorder apart with over 80% accuracy. That's really encouraging. It means that if you've chosen assessments you can be confident in, you're already over 80% of the way there. But this same study found that when we also add in the presence or absence of a manic or hypomanic episode, that accuracy increases to up to 95%. So use this history taking in combination with any assessments that you choose. There are differences in the depressed mood as well, and that can also help differentiate bipolar disorder from BPD. While both groups report feeling hopeless and helpless, someone in a true depressive episode is going to engage in lots of negative self-evaluation, and that hopelessness will be directed inward. Dysthymia, like we see in BPD, is typically more focused on others and the social context. Dysthymia, as seen in BPD, is also a lot more irregular in duration. It may shift day by day or even hour by hour. This is because in BPD, depressed mood is much more responsive to the social environment, and in major depressive disorder or bipolar disorder, much less so, much more stable. It's also important to assess whether there has been any time that your client was not depressed. To borrow a quote from Kernberg and Yeomans, quote, "There are patients who report they've been depressed all of their lives, and these patients usually present severe personality disorders," end quote. This is because people suffering from a mood disorder will also experience periods of relief. Finally, consider the overall pattern of symptoms. To borrow an analogy from our previous webinar on this topic, bipolar disorder is a lot like Neapolitan ice cream. The manic, depressed, and normative states are clearly separate and clearly defined. When there's a little bit of each mixed in all of the time, what we're seeing is much more likely BPD. And this is so important because it really does shape our treatment recommendations. We'll discuss this more later, but medication is very important in the treatment of bipolar disorder, and much less so in BPD. Another condition that commonly gets confused for BPD is post-traumatic stress disorder, or PTSD. Further complicating this picture is the fact that there is a body of research to demonstrate a relationship between BPD and PTSD, but the role of the trauma in this relationship is unclear. Here are some of the things that have been proposed. The first is that trauma, especially early life trauma, causes both BPD and PTSD. Another hypothesis is that the association between childhood trauma and BPD is actually due to a genetic predisposition to BPD symptoms. Those symptoms in parents mean they create a traumatic environment for their child. So it's really the BPD that's being inherited but causing the trauma. Another hypothesis is that some of the symptoms of BPD put adolescents at an increased risk for trauma. Those impulsive, risk-taking behaviors can mean that adolescents with a diagnosis of BPD get exposed to trauma more frequently than those without. Whatever the reason for this relationship, rates of comorbidity are very high between these two conditions. The picture gets even more complicated when we consider the diagnosis of complex PTSD, or CPTSD. Now, complex PTSD, for those who are unaware, is a diagnosis which exists in the ICD-11, but not in the DSM-5. As described by Cloyter and colleagues, both manuals broadened their symptom criteria for PTSD. DSM-5 did this by adding symptoms to the PTSD diagnosis to account for chronic negative changes in mood, cognitions, or behaviors. The ICD-11 did this by creating a diagnosis separate from PTSD, complex PTSD. In the ICD-11, symptoms must be expressed for each of 3 domains of PTSD, including re-experiencing, avoidance, and a sense of current threat. To further meet criteria for a diagnosis of complex PTSD, an individual must also have symptoms from each of 3 domains of disturbances in self-organization, which includes affect dysregulation, negative self-concept, and disturbances in relationships. A person can't meet criteria for both PTSD and CPTSD. But CPTSD is considered a more severe and functionally impairing form of the disorder, and one with more points of overlap with the diagnostic criteria for BPD. So how do we tell these two apart? One way is to look at the symptom onset in relation to the traumatic event. It's typical for symptoms to present within 6 months of the traumatic event in PTSD. If they begin later than this can be evidence of a personality disorder. Kernberg and Yeomans further state that the type of symptom matters as well. Symptoms like somatization, dissociation, emotional lability, impulsivity, self-destructive behaviors, and chronic interpersonal problems are much more typical of a personality disorder and relatively rarer in PTSD. Researchers of CPTSD have also identified many ways to distinguish the two. To quote Cloyter and colleagues, quote, "The presence of emotion regulation problems does not distinguish CPTSD from BPD, although the severity and type might," end quote. Emotion regulation problems are seen in both conditions, but the way that they present is important. If the emotion regulation takes the form of emotional sensitivity, difficulty calming when distressed, and chronic numbing of emotions, that's more typical of PTSD. But if what we're seeing is emotional lability, uncontrolled anger, and self-injurious or suicidal behavior, that's much more typical of BPD. Both conditions also demonstrate patterns of relationship disturbances, but again, these look somewhat different. If relationships alternate between enmeshed and disengaged, and there's lots of fear of abandonment, that's a lot more typical of BPD. Whereas if your client tends toward avoidance and detachment and expresses fear of closeness, that's much more typical of PTSD. Cloyter and colleagues performed a latent class analysis to determine what predicts belonging to the BPD diagnostic class and the CPTSD diagnostic class. And the biggest predictors they found of belonging in the BPD group were frantic efforts to avoid abandonment, unstable relationships, an unstable sense of self, and impulsivity. As with bipolar disorder, the reason it's so important to draw this distinction is that treatment recommendations for BPD and PTSD are very different. Treatments for PTSD focus at their core on ameliorating symptoms related to the trauma memory. Priorities in BPD treatment include resolving self-harm, suicidal behavior, and other dangers to the self, as well as reducing dependence on others and creating a more stable sense of self. And before we wrap up with our assessment section, I also want to talk about how gender can affect the diagnosis of BPD. Per the DSM-5, BPD is diagnosed primarily in women. And when they say primarily, they mean to the tune of 75% of cases. However, studies have demonstrated that gender differences in population-based samples are not significant. And this is true in both adult and adolescent samples. So what's going on? One of the biggest hypotheses is that men and boys seek less services for their mental health problems than women and girls, in part due to these being more stigmatized for men and boys. It's also possible that men and boys have lower willingness to disclose symptoms of BPD. Symptoms like emotional instability, sadness, or intense suffering may be viewed as particularly unacceptable for men and boys. And finally, there might be bias in our diagnostic procedures or in the way that we apply them. Our measures might be created and normed more for women and use language that bring women and girls to mind more than men and boys. And we as clinicians might be more willing to see these signs in women and girls and use these diagnostic procedures than we are for men and boys. So are there any actual gender differences in symptoms? The short answer is no. At their core, BPD symptoms look very similar for girls and boys. But there are some more subtle differences in behaviors, and there are differences in some of the comorbid conditions that we see. Men are more likely to demonstrate explosive temperament and engage in novelty seeking. They're also more likely to have comorbid substance use disorders and comorbid antisocial personality disorder. And because of this, they sometimes come to treatment through non-traditional channels, like through substance abuse care or through the criminal justice system. Women are more likely to have comorbid eating disorders, mood or anxiety disorders, or PTSD, and they might be much more likely to come through traditional voluntary outpatient therapy. In both boys and girls, we find that childhood ADHD or ODD is predictive of BPD symptoms in adolescence. So the bottom line of all of this, don't ignore symptoms in your adolescent boys, especially for boys with histories of ADHD and ODD, a history of self-harm or suicidal behavior, or a history of substance use or other risk-taking behavior. So at this point, you've hopefully chosen screening or interview measures that give you confidence in your diagnostic strategy and done a careful assessment of behavioral observations and history to rule out conditions other than BPD where not appropriate. Next, we're going to talk about how we deliver this diagnosis to clients and families, and what are the treatment implications that we can give them for a child newly diagnosed with BPD. So the first step is to acknowledge our own stigma or our own anxiety. This can feel like a very big conversation to have with a client and family. The thing to remember is that good diagnostic conversations arise from good assessment. The more you've done your homework in choosing an assessment strategy that gives you confidence, the easier this conversation is going to be. As with all other big conversations, if you're feeling anxious, practice what you want to say ahead of time, in the mirror, with colleagues, with your supervisor. And when the time comes to have this conversation, be careful not to overtalk. Say just what you need to say and give child and family time to ask their questions. It's also really important to check in with yourself about any stigma that you may hold surrounding this diagnosis. We know that stigma is out there, even in mental health workers. Mackenzie, Gregory, and Hogg reviewed the literature regarding mental health worker attitudes toward individuals with BPD. And what they found was that mental health workers held more stigmatized beliefs toward individuals with BPD than they did toward individuals with other mental health problems. This affected the way mental health workers behaved toward their individuals with BPD. They made more negative predictions about their ability to build a therapeutic alliance with these individuals. They believed that these individuals had worse prognosis in treatment. They experienced stronger countertransference towards these individuals. And as a result of all this, they reacted with less empathy and more dismissiveness and judgment. And we can see how that would shape the experience of an individual with BPD who is already relatively sensitized to the social context. So if this conversation feels like giving bad news to you, remind yourself and family that receiving the diagnosis actually changes nothing about your client's experience. It doesn't add anything to their child, and it doesn't change anything about their child. It's just a description for what was already there. It can also be very helpful to educate yourself about the nature, causes, and treatability of BPD. What Mackenzie, Gregory, and Hogg found is that education and experience with this population were the two surest ways of reducing stigma. It can also help to remember that personality disorders exist on the continuum of normal personality. We'll talk more later about how to apply the DSM-5 alternate model to our case example. But in the DSM-5 alternate model, borderline personality disorder can instead be viewed as an excess of negative affectivity, which is just neuroticism from the Big Five, and an excess of disinhibition, which is just conscientiousness. In adolescence, we can also view personality disorders as personality development that's simply gotten off track. Personality disorder researchers look at the development of personal concerns in middle childhood and narrative identity in adolescence. And when these are off track, adolescents may have difficulties understanding the motivations of others or formulating a consistent identity. But just because it's gotten off track doesn't mean that treatment can't help adolescents get back on track with their peers. So when we think about how to actually deliver this diagnosis to clients and families, it can help to borrow ideas from therapeutic assessment. Therapeutic assessment, for those who are unfamiliar, is a collaborative, structured method of doing psychological assessment that views the assessment as an intervention in and of itself. The main goals of therapeutic assessment are to make the assessment beneficial to clients by involving them in every step of the process and helping them make sense of their assessment findings in their real life. Therapeutic assessment has been found to increase client satisfaction with care, their feelings of therapeutic alliance with providers, and make them feel more prepared and motivated for continued care. When working with children, Theringer recommends that a clinician seek to build a therapeutic alliance with the client and with their family. and to give both client and family a chance to voice their questions at every stage of the process. When it comes time to give feedback, they suggest to give the feedback to family first and then to your client with their family present so that everyone has the same language and the same understanding. When we're giving feedback, Finn recommends to start with level 1 or familiar feedback before moving to level 2 and finally level 3, that contradictory feedback. Level 1 feedback assessment findings are the things that fit with the way your client already thinks about themselves. This would be feedback like, you experience emotional highs and lows, often within the same day. This won't come as a surprise to your adolescent. It's probably something they reported to you. At this level, stick closely to what they've reported, whether in sessions with you or during the course of the assessment. Level 2 feedback are assessment findings that might either reframe or amplify the way that your client thinks about themselves. For adolescents with BPD, learning that they have BPD is probably level 2 information. This is feedback like, based on what you've reported to me, your symptoms fit with a diagnosis of borderline personality disorder. It's probably not going to be earth-shattering, especially when you explain it in terms of all of the level 1 information. Level 3 feedback are assessment findings that contradict with the way your client thinks about themselves. If you have an adolescent who comes to you with a diagnosis they feel attached to, but is ultimately incorrect, that would be level 3 information. This is feedback like, now it seems that the symptoms which you have been told are bipolar disorder are actually part of borderline personality disorder. Bipolar disorder doesn't seem like an appropriate diagnosis for you at this time. Now, Finn's advice is to give level 3 information last, but still to give it. He reflects that clients will continue to think about this information and assimilate it into their understanding of themselves, even long after the assessment is over and the feedback is given. So even though client or family may still have questions or not agree in the moment, that doesn't mean that they won't think it over and come to agree with time. Overall, our goal at this stage should be to use the assessment feedback to increase families' empathy for their child, which might be really low based on some of the symptoms child might be showing, and to also increase your client's understanding of themselves. Next, we're going to talk a little bit about what treatment recommendations we can provide to these clients and their families, and I'll have Dr. Scallon start with medication recommendations.
Thank you so much, Dr. Lee. That was great. I totally agree. And this slide is a great segue from what you were referring to, which is that sometimes when we give the diagnosis of borderline personality disorder, it can be new information. And sometimes it can be contradictory with what they have heard before. And along those lines, lots of times when we see kids, they have been prescribed many medications in the past. They have, often, had multiple medication trials. And what we often hear is that none of them helped, or maybe they helped at first, but they didn't seem to continue to help, or something like that. But not surprisingly, and it's okay, but, the severity of the symptoms of these young people really does lend itself to trials of medications, and also the confusion about whether or not to use the diagnosis of borderline personality disorder lends itself to the confusion around medication use as well. But to boil it down to a very simple point, there is no medication to treat the core symptoms of borderline personality disorder. Essentially, it is not the right tool for the problems. And so we do use medications to treat the coexisting symptoms of depression, anxiety, sometimes impulsivity, or extreme emotional reactivity. And so it's not to say that we don't use medications for those symptoms, and we'll touch on that a little bit more later. But there is not a medication to treat the core symptoms of BPD per se. So there was recently a review in 2020 that found that any kind of research into this topic has been declining. We don't have any evidence that a medication helps, but medications are often tried. And often what we see is polypharmacy, or the use of many medications at the same time. And again, I fully understand that well-intentioned people start the medications because there are many crises and concerning kinds of episodes. And so people try, but what can often end up happening is it's like putting a Band-Aid on top of a Band-Aid on top of a Band-Aid, and then the people persist in taking the medications, and then old Band-Aids are no longer helpful, and they can even get in the way and cause their own problems. So that is similar to what we see sometimes with medications. Okay, with that, I'll toss it back. Thank you.
So what we do recommend, since medications aren't really going to treat the core, would be a therapeutic approach. And there are two main therapies that have demonstrated some effectiveness for adolescents. The first is dialectical behavior therapy for adolescents, or DBTA. DBTA is a comprehensive principle-based treatment which was developed for adolescents in outpatient care who engage in self-harm and demonstrate borderline traits. Its focus is on teaching skills, mindfulness to stay in the present moment, distress tolerance to cope through crises, emotion regulation to improve overall emotional functioning, and interpersonal effectiveness to improve social functioning. It's a multimodal treatment, meaning that lots of different kinds of supports are offered, and there's a high degree of contact with your clinical team. There are individual sessions, multifamily skills training groups, and also phone coaching available when there's between session crises. So DBTA differs from DBT for adults in a couple of ways. First, its course is meant to be shorter. Whereas it's meant to last about a year in adults, it's shortened to last around 3 to 5 months in adolescents. Second, caregivers are included in the weekly skills training groups, and the goal is for caregivers to receive and practice the skills at the same time as their adolescent is practicing the skills. Because of this, they also lengthen skills training group a bit from 90 minutes a week to 120 minutes a week. Randomized controlled trials have been performed to compare how DBTA performs to control treatments. The control treatments are designed to control for the multimodality of DBTA, and in this comparison, DBTA is superior for reducing self-harm, suicidal ideation, depressive symptoms, and suicide attempts. Now, interestingly, in both of these studies, the control treatments still had some effect, though not to the degree of DBTA. As a result, authors of the later study conclude that DBTA is, quote, the first well-established empirically supported treatment for decreasing self-harm in youths at high risk of suicide, end quote. Now, DBTA can take a lot of training and supervision to disseminate, and so it isn't available everywhere. Where DBT isn't an option, there's another treatment that can be supplied, and that is mentalization-based treatment, or MBT. MBT is a psychodynamic treatment which draws from attachment and cognitive theory. Mentalization-based treatment was originally developed for outpatient care. The main goal of this treatment is to strengthen your client's ability to understand their own and others' mental states. The idea is that the core pathology of BPD involves a tendency to shift to a non-mentalizing state when emotionally aroused. That means that your adolescent no longer understands their own or others' behaviors, leading to higher risk-taking in those moments. MBT can be offered in group, individual, and family format, and according to Bateman and Fonagy, MBT may take less training and supervision than DBT, and therefore be easier to spread. However, its effectiveness might depend upon its format. One study done fairly recently in 2020 found that group-based format was not superior to treatment as usual, but another study found that individual plus family format significantly reduced self-harm, depression, and symptoms of BPD. Now, there are other therapies that have been developed for BPD in adolescents. Reviews describe therapies like emotion regulation training and cognitive analytic therapy, but these do not have the same evidence base as DBT or MBT. These reviews, done in 2019 and 2021, do also raise significant concerns about the status of evidence-based treatment for BPD in adolescents. The older review found that psychotherapy does decrease BPD symptoms and non-suicidal self-injury, but effects may not be maintained. The second study found that there's a lot of bias in the studies that have been published so far. It's usually the developer of the treatment who is testing the treatment. And sometimes treatment is not superior to treatment as usual. DBT and MBT are currently the only standalone treatments which are evidence supported in adults, and these still require replication. So this is why DBTA and MBT would be the two that we recommend as well. Unfortunately, the years of being unable to diagnose BPD in adolescents means that this is an emerging field of research. We might find in the future that there are other effective therapies, but for now, those are really the two that we would recommend. Something else I want to throw out there is this MOBI study, which was very interesting because it compared two service models and two forms of individual psychotherapy for the early intervention of BPD. There were 3 treatment arms in this study. The first group received HYPE and cognitive analytic therapy. The second group received HYPE and befriending. And the third group received YMHS and befriending. And I'll describe these conditions briefly. HYPE and YMHS are both service models, so it's a way of providing care. Both of them involve psychoeducation, case management and planning, psychiatric care, and when needed, crisis services and inpatient care. But there are some key differences. HYPE was designed based on the principles of cognitive analytic therapy. It's explicitly collaborative, and it seeks to psychoeducate not just your client, but also their families, schools, and support systems. It focuses on flexibility, recovery, and the use of plain language. And when inpatient services are utilized in the HYPE model, they're kept intentionally brief and goal-directed. YMHS, on the other hand, is basically treatment as usual. Cognitive analytic therapy is an individual psychotherapy that incorporates concepts from object relations and cognitive theory. Its main focus is on the client's self-management and their relationships to other people. The client and clinician work together to reformulate what the client's difficulties are to increase their understanding of themselves. And finally, befriending is basically an individual psychotherapy stand-in. This is where the client meets with a clinician once weekly for an hour and discusses neutral topics. It's meant to control for access to services and the therapeutic alliance while avoiding anything difficult. So based on the way I've described these conditions, we would probably expect that the HYPE plus cognitive analytic arm would have the most benefit. Those are 2 active treatments. And HYPE plus befriending would probably come second place. And YMHS plus befriending is a double control, so it would probably come last. Very interestingly, all 3 interventions were equally effective in restoring psychosocial functioning in this age group. And that raised questions about what the essential parts of treatment are. Remember too, that some of these control conditions in these other studies also experienced benefit. So what does an adolescent actually need to be successful in treatment? These are the 3 things that we believe to be the essentials. The first is a solid treatment model for understanding BPD and something that all of your other interventions tie back into. One reason the DBTA and MBT are successful is because they offer these. In DBTA, that treatment model all centers around emotion dysregulation as the core, which causes problems with distress tolerance and interpersonal effectiveness. The goal is to teach skills which help an adolescent increase their ability to regulate their emotions. In MBT, The core is a lack of understanding of one's own emotions and the emotions of others when distressed, which causes strong negative cognitions about the self and isolation from other people. And the goal is to help these adolescents be able to mentalize even when stressed. So the first important thing to have is that solid treatment model. The second essential to have would be good clinical case management. And this includes hospitalization when necessary, but also very importantly, keeping your clients out of the hospital when it's not necessary. Because while hospitalization will sometimes be needed to save a life, we also want to minimize reliance on hospital systems and maximize reliance on internal coping. And Dr. Scallon, if you want to speak to the third essential.
Great, thank you. And like I mentioned earlier about medications, we do use medications to treat coexisting or comorbid disorders such as anxiety and depression. Usually we use SSRIs to start with, Lexapro, Zoloft, Prozac, some of those. Those treat both anxiety and depression. We use behavioral activation, which I'll talk about just a little bit further, which is a behavioral intervention to treat depression. Occasionally when people are really, acting out in ways that are aggressive or they're extremely dysregulated and we need to kind of manage those, occasionally there can be the short-term use of medications such as antipsychotics or what's called mood stabilizers sometimes, but hopefully those should be rare. Thank you. Okay, with that, we're going to transition to the next part of our talk, and we're going to talk about a case example. And I'm going to be presenting a case of a 14-year-old girl who admitted to our residential care unit here at Rogers. I'm the child and adolescent psychiatrist and medical director of Focus Adolescent Residential Care. We treat teens ages 13 to 17 for mood disorders, and our average length of stay is 6 to 8 weeks. But more commonly, we do often have kids who have BPD and who have coexisting, anxiety and depression, ADHD, trauma, eating issues, learning issues, and a variety of other coexisting disorders. I'm going to talk about a few topics that are important in our work here. And so I'll just mention those just to tag these words as we go through them. One of the terms we're going to use is distress tolerance. Another one is splitting. Another one we're going to talk about is willingness. We're going to talk a little bit more about behavioral activation. Going to talk about illness identity. We're going to talk about accountability versus accommodation. Accountability versus accommodation, big difference. Extinction burst. And we're going to talk about using a model that describes lagging skills and skill building as opposed to using a medical model. And we're going to talk a little bit about the importance of parent education, as well as just touch again on DBT. So the case I'm going to describe was a girl, 14-year-old girl named Maya, who was admitted to our program with the following diagnoses: DMDD, disruptive mood dysregulation disorder, generalized anxiety disorder, ADHD, autism, and bedwetting. I want to really highlight the diagnosis of autism spectrum disorder because this was kind of the primary diagnosis that this child and her family identified with. She was medically fairly healthy. She lived with her married biological parents. Her mother worked in a school as a therapist of sorts, and her father worked in business. And Maya herself was a ninth grader completing courses online because of school refusal. She came from a fairly small town, lived with two younger siblings, and she was coming to us after having, oh, I'm sorry, you could advance the slide, after having 3 previous inpatient stays before she came to us. She also had 2 partial hospitalization programs, and most of those inpatient stays were prompted by suicidal ideation. She was hopeless. She felt like nothing was ever going to get better. And the last inpatient team recommended that she come to residential care for a more extended therapeutic stay rather than just the stabilization that occurs in inpatient. And so she was also prone to self-harming with sharp objects that she would find or break, such as pens or broken glass. She had taken multiple medications in the past. This is actually a partial list, but I'll name some of them. Buspar, mirtazapine as an antidepressant, and she also took a couple of other SSRIs. She took Lamictal, which was a mood stabilizer, ADHD, including Concerta, guanfacine, Vyvanse. 2 of those are stimulants, Concerta and Vyvanse. She has taken several antipsychotics, Abilify, Rexulti, Risperidone, and various other medications that were either just treating specific symptoms or were treating side effects from the other medications. But one thing that the family and Maya were both very clear about was that none of these medications had helped before. Next slide, please. Parents reported the following behaviors. They said manageable. She used screens excessively and almost exclusively and filled her time with this. There had been times that they had tried to take her phone away due to her sending nudes to a boy, as well as other fairly explicit video selfies. And she became so angry and upset by this that they ultimately gave it back to her because they were just having such difficulty managing her behavior. She had longstanding difficulties with maintaining friendships due to, quote, friendship drama. Sometimes friends would say she became too clingy. She had a lot of disputes with friends, and that may have been part of the reason that she switched schools because of peer relationships. In fact, it was. She also really enjoyed volleyball, but she quit her volleyball team because she felt that teammates bullied her. And when asked what she meant by that, she gave the example that the coach of the team had a policy that if one of the players was going to miss practice, that they needed to text the rest of the whole team to say, I'm not going to be there today. And then the other kids, would say, oh, come on, we really need you and you have to be there. And Maya told me that felt like bullying to her, and she interpreted that negatively and quit the team, which was really sad because she enjoyed volleyball. And like I said, she did switch schools, and she currently switched to a school where her mother was working. Okay, next slide, please. Parents also reported that she would not comply with just basic chores around the house, such as just picking up after herself. They said her bedroom was just, a disaster, and junk everywhere, clothes, you name it, and she wouldn't pick that up. And if they asked her, eventually she just became so angry and escalated that they dropped that expectation. Also, she had severe emotional outbursts, throwing things, cussing, yelling, refusing, door slamming when they tried to repeat the limit or when they tried to impose any consequence. She also did not do homework. They described that they started to try to keep the peace and, quote, pick their battles. She had multiple medication trials, which I mentioned. Some of those, it's interesting when interpreting medication trials because it's really hard to tell what is a behavioral side effect what is a medication not working, or what is something that just would have occurred anyway in her life. And so I can tell you that, these medications corresponded in time with when she was taking, I'm sorry, these behaviors corresponded in time with when she was taking these medications, but I can't make the attributions that those were the reasons that she behaved in those ways. For example, they said that Zoloft made her, quote, go berserk for the whole summer. She sent nude photos while on Rexulti. Lamictal caused rash and hives. Excuse me. Vyvanse increased her anxiety, and mirtazapine made her sleepy. So again, I can't make that attribution, but those did correspond in time. Okay, so we're going to switch a little bit to talking about her assessment scores. And in this case, on our unit and with Maya, we are really pivoting from a medical model of basically like an affliction that, you have kind of been stricken with, to a model of what we call lagging skills. The idea being that these are skills that you can learn and develop and practice and catch up on. And that is part of DBT. DBT refers to the idea of catching up on lagging skills. The good news is there's very good prognosis when you do that. And so this is not throwing your hands up or giving up kind of a process. In fact, we see that it is really quite effective, empowering, and something that is readily accessible to kids and families. There's one issue, and that is that you really need willingness to kind of embark on gaining these skills. It's a curriculum, you have to learn it. And so it takes some, engagement in the process, and also some belief in the diagnosis of borderline personality disorder. And I really liked how Dr. Lee talked about those levels of information giving, or I forgot the language that she used, but it really is true. First, you join someone with where they are, and then you sort of amplify that, and then you can talk about information or an interpretation that might be somewhat contradictory with how they had interpreted those things before. Again, not changing what was the original prompting, behaviors, but interpreting them through a different lens. Okay, so in order to gain skills, we really do need willingness, and along the lines of our program emphasizes something called behavioral activation. Sounds like a big, formal, professional, stuffy word. Really, what it refers to is that we don't wait to get motivated. We don't wait to get undepressed to change our behavior. We change our behavior, and our motivation follows. So that is huge. Just kind of sit with that for a minute. It goes back, sometimes we call that grandma's rule, right? Like what did, people say a long time ago? You're kind of gloomy and down, and you say, well, why don't you go, out in the yard and rake the leaves for the elderly neighbor, or something like that. And if it sounds, invalidating, it's really not intended to be. There is a great evidence base that behavioral activation works. So we're not just saying it, we're not trying to invalidate people. If you think about the triad of mood, thoughts, and behavior, it is not effective. And in fact, it is somewhat invalidating to tell someone, well, change your mood, cheer up. Intervening at the level of the emotion is not effective. But we can intervene at the level of behavior and cognition. And so it's more accessible to intervene at the level of behavior. Again, starts with willingness. You have to be willing. If you get up, take a shower, brush your teeth, and put on clean clothes, you will feel better than if you hadn't. And so there are a series of micro mood improvements. Again, this can bring up a lot of strong feelings for people, and I understand that, but that is kind of the idea behind it. And there is that issue of willingness. So we don't wait for motivation to change behavior. We act with the idea that mood will follow, and we sort of lead with micro mood improvements. Okay, back to Maya's assessment scores. She did endorse, these are self-reports that she does on a tablet, and she does these weekly. She reported initially that nothing was working. and that she was not functioning well at home, school, and socially, and she felt discouraged. Okay, she was not activated, meaning that she was kind of laying around on her phone, not doing things. We divide up behavioral activation into 3 areas. REV, I kind of think of it, or I remember it as rev your engines, routine, enjoyable, and valued activities. And so usually people with low activation are not engaging in routine activities like hygiene, enjoyable activities, things they like, music, outdoors, animals, whatever the case may be, or valued activities, things like homework, or writing a thank you note to your, somebody that gave you a gift. Okay, and then she also did endorse high anxiety, both socially, and she described a lot of discomfort with anxiety. She was uncomfortable with those feelings. Specifically rejection sensitivity. And we see that a lot with kids who have borderline personality disorder. They have what we would characterize as rejection sensitivity. It's kind of an interpersonal sensitivity. It's exquisitely painful to be receiving negative feedback from socially, or to feel excluded. So this, interestingly, was part of what had been characterized, or at least in part, as autism, that she was, and she had a lot of, social difficulties, reactivity, ruptures in relationships, and that she was not socially skilled or effective. And so that was part of her, part of that social part. And on our unit, she began engaging in our residential treatment program. We have mindfulness to begin each morning. We have a lot of assignment time, which emphasizes assignments with CBT and DBT. CBT, again, being that triad of emotions, thoughts, behaviors, and DBT with the 4 modules that were dialectical, focuses on the idea that 2 opposites can be true at the same time. And so 2 of the modules in DBT operate from a principle of acceptance. Those are those are mindfulness and distress tolerance. And the 2 that focus on change are interpersonal effectiveness and emotional regulation. Okay, so that's where that word dialectical comes from, that curriculum of the 4 modules, that 2 opposites can be true at the same time. We can both accept and we can change. We also have experiential therapy on our unit 5 days a week, where we get the kids doing things. We take them to play mini golf and bowling and the pottery studio, and take them to the domes in Milwaukee and the museums, and we have kayaks, and we take hikes in the state park and the pumpkin patch and the apple orchard and all those great fun things. And it's really great. And it's always so fun to be on the unit when the kids come back from those outings and they're laughing. And I love it if they come back and they're wet because they were kayaking and they got splashed or whatever. Really, really great stuff. So a lot of times there's a little bit of resistance to going before they go. I hate that, or I don't have the right clothes, or the bugs are too bad, or it's too hot, or it's too cold. And after they go, they are laughing and they have had a good time. And often we hear that on the weekends, they want to take their parents bowling, or, something like that. So that's really great. And hand in hand with that model of behavioral activation. And then we also have individual sessions with our therapist, which focus on reinforcing the DBT skills that they learn in groups. And so we're reinforcing some of those. DBT, if you're not familiar with it, is really interesting, very accessible, uses a lot of acronyms, which are basically prompts for the skills. So, RC, respiratory control, TIP, dear man, accepts, distracts, the give skill, ride the wave, radical acceptance, pros and cons, using a half smile. So really good, helpful skills. Won't get into those details. We also focus on communication, using assertive communication, meaning not passive, not aggressive, not passive aggressive, but rather that middle path of assertive communication, which is respectful to self and others, and straightforward and honest. Okay, so how was that received? Well, we made the diagnosis by reviewing the BPD criteria with the parents. Essentially the CI BPD that Dr. Lee referred to. We go through the 9 criteria in the DSM, and you need to meet 5 out of 9 to make the diagnosis. And so, if you meet 5 out of 9, that means that BPD can present differently in different people. If you meet different, if you're 5 out of 9 or different from your friends 5 out of 9, you might have a pretty different presentation, but it doesn't mean that the diagnosis does not still fit. So the 5 out of 9 that she endorsed, she did endorse feeling, or more than 5 out of 9, feeling abandoned, feelings of abandonment. She was very sensitive to feeling abandoned by her parents. They live quite far away. If they didn't drive here both days out of the weekend for a pass, she felt very upset and abandoned by them. She was clingy with friends. She had a lot of dramatic relationships. She was impulsive. She cut her hair. She sent nudes. She ran away from home. She broke things that she regretted, things that she really liked. When she was angry, she had lots of suicidal behavior, gestures, and threats. A lot of mood dysregulation. That's where that diagnosis of DMDD came from. She endorsed feeling very empty, and she had a lot of anger, and that was very apparent. We conveyed it first to parents and then to Maya, and the parents were confused by that, in part, very understandable. They had a neuropsych evaluation when the patient was 9 years old by a person that thought that she had autism, largely referencing that she was very sensory sensitive to like clothing, textures and food, sounds, and also she had had considerable social difficulties. That was around the time of COVID. I'm not so sure, I don't think that would be replicated in some of the same way, but these are very highly motivated, kind and loving parents who wanted to do the right thing. And they, kind of did all they could to seek out help for autism. If you meet Maya, I think most people would say she did not appear qualitatively to have autism. She was very tuned in to other people. She was not particularly interested in objects. She was very interested in her appearance and having the right clothing. And she would sort of, if anything, kind of overread cues that she received to other people. The model of care they had before they came to us was an interesting one. They were seen at a clinic for kids with who are neurodivergent. And so the parents consulted with more of a parent consultant, but not a therapist per se, to the patient. And that therapist would try to give them ideas to help prompt her behaviors. Like, maybe she needs visual cues to clean her room. Start with your clothing, then pick up all the plates in your room, then do this, and she was trying to kind of sequence it in the way that perhaps a child with autism might benefit from more. But that really was not helpful for Maya. We did collaborate with that therapist who was very open to pivoting away from her model. She said, frankly, I don't really know her, spend time with her. I spend time with the parents. And the other part of the treatment was that Maya was seen by county a kind of county in-home team who were working on really rapport with her, de-escalation techniques a lot of the time. And parents said they didn't really find it that helpful. And most of the time, Maya wanted them to take her to get an iced coffee, which they did. And parents were, understandably sometimes grateful for the respite, but none of them really felt that it was all that helpful. Okay, just to go back to that autism diagnosis, she did not have early language delays, and that her relationships became worse as she got older, but some of those social difficulties were not there when she was younger. She did not have restrictive or repetitive behaviors. The medications over time, I'm speeding up, were tapered down. We did discontinue the atypical antipsychotic. She left us on a SSRI and a stimulant medication. I do think she did have ADHD. She had a lot of executive function difficulty. I think I'm going to jump ahead. We did talk about polypharmacy. We talked a lot about increasing distress tolerance and learning how to manage emotions. We provided psychoeducation to parents and had very open discussions with them about how this model was very different from what she had had before. And they were kind of struggling with how to, whether to just fully discard that previous model, fully take on BPD. I think dad was more open to it, and the mom was less sure. And so, and she was concerned about how she was going to kind of manage the other kids. We also talked about this concept of an extinction burst, that, in order for there to be a change in Maya's behavior, parents were going to need to be very allied, and that often behavior gets worse before it gets better. In this case, we call that an extinction burst. And they kind of said, boy, I don't know that we can do that. And, things are so tricky as they are. As an example, we did bump into splitting. I think it came in part by the parents' confusion about this. One example was Maya wanted to get highlights in her hair while on pass, and we we did allow that, but we said, okay, we have to make that therapeutic. And we want her to get practice tolerating a no. And so where normally they would go shopping and get, a mani-pedi afterwards, and she would get highlights, and it would be a very expensive day. And, Maya would come back with a lot of new clothes and a lot of money. We said, please bring sandwiches from home, thermoses, comfortable shoes, and, get the highlights. But then afterwards say, we're going to try something new. We're not going to go to Starbucks, and we're not going to go to the mall, and we're going to do something else. And the mom, said, I really struggle with that. It feels like a punishment. I'm not sure that's fair to her. And also I enjoy it. And that's what we like to do together. And, we said, okay, I understand that. And also, let's try it just this once and see how it feels. And then you can report back about that. But that was a very charged situation. So that was just one example where we had to talk to parents about their distress in managing Maya's distress. Can you tolerate feeling uncomfortable when your child is uncomfortable? And so that was sort of what we did. We talked a lot about radical acceptance for Maya, and she was going to tolerate the no. Okay, so just this last slide that I'll breeze through. We worked with Maya on trying to help her identify her own emotions. That was new to her. She really did have quite a wall up, and she had to learn how to be honest and vulnerable. And, that was a work in progress. We talked about when to use the hospital and when not to use the hospital. We said, gee, she's really learning a lot of these ideas. We know emotions are impermanent and we can tolerate distress. Can you supervise her during the times that she feels really at risk? And they said, we'll see. We talked about the times to use the hospital is if a child is combative or they're actively self-harming or they're unwilling. We also talked about step down to PHP, and that we recommended that she continue to use DBT after step down. Okay, thank you.
Skip over some of these. See here.
Perfect. Thank you so much, Dr. Lee and Dr. Scallon. And again, the slides will be available to you on your personal CE-Go dashboard. And so we'll have a list of references and all of those pieces that you'll be able to access after the broadcast today. So if you do have any questions, please use the Q&A box to submit those. We do have a lot of questions that I will be putting together themes as well. But if we don't get to your specific question, please send us an email message after the broadcast to webinars@rogersbh.org, and we will follow up with you. So one of the first questions is there a minimum age for a diagnosis of BPD in adolescence?
The best research we've found is down to age 11.
Okay, perfect. Multiple questions about autism spectrum disorder and BPD, co-occurring differential diagnosis, and then also treatment of. So I'll throw that to both of you.
Say, in my experience, I think it's the social difficulties that get confused quite frequently, and the emotion dysregulation too. We see that in both conditions, but when we talk to adolescents about the reasons for emotion dysregulation, it seems to be so much more social in BPD. And then in autism, it's so much more to, I was overwhelmed with sensory information, or a routine was disrupted and I wasn't sure how to cope, or I was interrupted in something and didn't know how to cope. So that seems to be one piece, is like, is the dysregulation related to something social, or is it related to something non-social and more like routine?
And would you shift treatment or treatment goals based on that information? How would that look?
I would just say these skills are really helpful to anybody with lagging skills. And so, no, I think I would, if the child is cognitively able to benefit from DBT, if they're willing to engage, that could be a helpful treatment modality.
Thank you.
I would say we tend to apply DBT and CBT regardless. It's just maybe the goals look a little different. I think for autism spectrum disorder, we're trying to engender like that flexibility of thinking and responding to change. And then BPD, it is like building those skills for emotion coping.
Thank you both. Several questions about PTSD and BPD. Diagnosis, again, similar diagnosis, treatment, what are you treating first? And then also an inquiry about, did Maya have a trauma history as well in your case example?
Do you want to go ahead, Dr. Lee?
Sure. I will say in terms of priority, because a person absolutely can meet criteria for both BPD and PTSD, I go back to the treatment priorities that they list in DBT. And basically we need to start with what's life-threatening. So if there is self-harm occurring, suicidal behavior that threatens your client's life, I would start more with like the DBT forward, building those skills type approach, because so much of the work with PTSD involves going back into the trauma memory, doing these things that are very difficult. And if the day-to-day is already overwhelming to them, I'd like to build up a base of skills before that. But then it becomes a matter of, what's treatment interfering, and then what's quality of life interfering. So I think it matters how severe each condition is and what we consider to be higher priority. Maybe once we take care of what's life-threatening, we can focus on trauma work, trauma-focused treatment. Maybe there's a few more things that are treatment interfering to address before that.
Yeah. Question, can you elaborate on accountability versus accommodating? And then to add one more on the end of that, what might accommodation look like in a school setting, or accountability look like in a school setting?
Yeah, right. Yeah, in this case, I'll take it to a really basic one. It was picking up her socks in her bedroom. And she was saying, I can't. And we were, it was like, you can, surely, you can pick up your socks. And it was good to have it sort of applied to such a very simple task. And so we wouldn't say, well, we understand, that you're flooded and so you can't pick up your socks. And so, we won't do it. Instead, we would say, let's just kind of be with this and pick up the socks, and we could take it one by one. And, if that's challenging for you to be curious about what is that, what's coming up right now? Is that a willingness issue? What does that mean? And I think in Maya's case, there was a lot of willingness or lack of willingness that got in the way. And to just explore that in and of itself is really helpful. So a lot of times just bringing it to something that is really simple and, isolating that and trying to understand, do you really need an accommodation, or are you trying to say something else right now with your behavior? What can that look like in schools? We really try in our unit to build what we call school stamina. So that means, in our unit, we don't have kids go back to bed throughout the course of the day. The doors to the rooms are locked, and we're not doing that to be punitive or unkind. We are really building, we're trying to say, gee, there will be times in your life when you can't go back to bed. And we're trying to show that if you push through it, you'll be okay. And that's part of distress tolerance. And so, sometimes when we call to schools, we have an interesting conversation because, folks in schools are very well intentioned and I believe, wanting to do all they can for kids and kind of using that accommodation model, is like it's all good and helpful. And we have been talking about the word accommodation, like, no, we have to do less of that. And we have to be encouraging them to do what they can do and to stretch that and build stamina and be more accountable. So like staying in class, for example, or if you go to the school nurse, you can go for 2 minutes, but then you got to go back to class. So not just, fully accommodating, to put some limits around the accommodations and then kind of pull them back little by little as a child is able to build their accountability and their stamina.
And what you were saying, Dr. Scallon, it's also all about what a child is capable of. I think accommodating depression in a school setting is really different than accommodating, say, a learning disability. That, even after treatment, that adolescent may need to receive materials like audio instead of having to read. That might be an accommodation that remains, but things that can change through treatment, like learning to use that internal coping and stay in class, those would be accommodations we would recommend school remove after they've been through treatment.
That's great. Thank you for adding that. That's a good point.
Thank you. We'll do one more question. And so when an adolescent is diagnosed with BPD and is not taking the recommendation to see a specific DBT therapist or engage in programming, how does a non-DBT therapist respond ethically? I would also add on that, if parents aren't willing to engage in that type of treatment modality or program, how do you navigate that as a mental health professional?
You want to go ahead, Dr. Lee?
It's a really good question. I think there's so many pieces to it. I think if I were an outpatient and I was giving a recommendation, especially to someone who's specialized, and I know that I'm not, that would be a big concern. I think I would want to work with child and family on what's getting in the way and what's making them hesitant to take the recommendation, and use some motivational interviewing to try to build us in that direction. And then as I think about like our own ethics code, I also have some obligation to help support that adolescent and help them remain safe to my ability until I can get them to the proper treatment provider.
Thank you. Okay, that is all the time that we have for questions today. And again, if I did not get to your question, please feel free to submit an email to webinars@rogersph.org and we will follow up with you. Please note that a recording of this program will be available via Rogers YouTube website, as well as on our resources page through the Rogers BH website. Before we conclude, I'd like to have our presenters just share the next slide of additional resources that we have available to you. These are just a couple of take-home messages for you all today. Again, you will be receiving the template of the forms that we have today, as well as resources. There was multiple questions about the different assessments that are available. And so if there are some resources available there, we can add those along. Within the next 30 minutes, you will be receiving an email link to your personal dashboard at CE-Go, where you'll be able to access the PDFs of the PowerPoint, as well as the references that I just talked about. For those of you who met the requirement today for time, you will be eligible for your CE credits. You will also use that CE-Go link to complete your evaluation, and then you can download your CE certificate at any time. If you have questions about the follow-up email or navigating CE-Go, please contact support@ce-go.com. Our community liaisons are looking forward to connecting with you to learn more about your practice, as well as talk to you about the treatment options available at Rogers Behavioral Health. On behalf of everyone at Rogers, we look forward to partnering with you and helping your patients. Have a great afternoon, everyone.
Thank you.